In this video, I'll be talking about hematinics pharmacology. The topic for this video is suggested by Mr. Debadatta Kumbar. First of all, anemia is defined as a condition in which the number of red blood cells in the circulation is decreased or their ability to carry oxygen to meet the physiological demands of the body is inadequate. And the hemoglobin cutoff levels to define as anemia varies by age, sex of the patient, the altitude at which the patient resides, various habits like smoking, and pregnancy status. For example, in pregnancy, there'll be hemodilution and various other physiological changes which occurs in a pregnant women, following which there will be increased demand for oxygen also because of pregnancy per se, and all these leading to different hemoglobin cutoffs to define as anemia in pregnancy. So this definition of anemia is taken from WHO. So the causes of anemia are broadly categorized as blood loss, which occurs suddenly or on a chronic basis, and the most important and most common cause of anemia is impaired red blood cell formation, and that's why I highlighted it separately. And among the impaired RBC formation, the most common cause among that is iron deficiency. Okay, it can occur because of iron deficiency, vitamin B12 deficiency, or folate deficiency, but the most common one is iron deficiency anemia. And so it's very important to know the management of iron deficiency anemia because it is associated with morbidity and mortality worldwide. And the third cause of anemia is increased destruction of RBC, as you see in hemolytic anemia and all that. So before starting to talk about the pharmacology of hemodynamics, make sure to hit the subscribe button and the bell icon nearby so that you'll not miss out any of my upcoming videos. Iron. Iron is the drug which is used for the treatment of anemia, especially iron deficiency anemia. Okay, so it's very important to know the dosage and various formulations available in iron. And before starting, you need to know that iron is given in oral route as well as parenteral route, and the most commonly preferred route is oral route. So first, let's talk about oral iron formulations. These are some of the most commonly used formulations. Of these, ferrous sulfate is the most commonly used formulation. And ferrous sulfate, although it is most commonly used, it is associated with various side effects like gastritis if it's going to be given on a long-term basis. So some recent formulations which are recently being produced uh, are replacing ferrous sulfate in various institutions. However, ferrous sulfate has very good efficacy in increasing the hemoglobin levels of the patient. So it is still very commonly used in various places. It's better to know at least 4 or 5 formulations to write in your exam. And if you're interested, you can know the entire list if you want. So these are some other formulations. These are just nice to know. It's not necessary to know all the formulations. You can just go through the list, and if it's fine, if you can remember all these names. So if you need to impress your examiner, you can quickly tell all the formulations you know. So let's talk about some principles which are involved in treating a patient with oral iron. Okay. So first of all, ferrous salts are better than ferric salts. This is because in order to understand this, you need to know the physiology of iron absorption. In the proximal intestines, iron is mostly absorbed in the proximal intestines. Okay, and in the heme form of iron which is present in the diet is very easily absorbed from the intestines. And apart from that, the inorganic forms of ions includes ferrous form and ferric form. Among that, ferrous form is the one which can be absorbed from the intestine. Okay, so if it is better that if the formulations which we provide has ferrous iron rather than ferric iron so that it can easily be absorbed. The second point is that elemental iron content should be considered in the dosage which we provide. For example, there's a tablet called Fersolate which is a 200 milligram tablet. Although it is a 200 milligram tablet, the elemental iron content in that tablet is just 60 milligram. So what really matters is that 60 milligram of iron rather than 200 milligram of that whole tablet, because it contains other constituents in the tablet to make it up to a 200 milligram tablet. Okay, so elemental iron content is all that matters to improve the anemia status of the patient, hemoglobin status of the patient. All right, so that is another principle that you need to consider. And third important principle is that sustained release preparations are found to be not so helpful rather than normal formulations. This is because of the fact that sustained release formulations will keep releasing the drug slowly, and it will release most of the dose in the distal intestines, as you know, like it will be constantly releasing the drug as it passes through the bowel. So um, as you know that most of the iron absorption is in the proximal intestines. Okay, so if the drug is not getting released in the proximal intestine, what is the point of releasing it slowly in the distal intestines where most of the absorption is not going to take place? So it is better to have normal formulations rather than sustained release preparations where it's not going to give any additional importance, any additional benefit. The fourth point is that liquid formulations of ions, for example iron syrup, should be swallowed without touching teeth. This is because uh, liquid formulations of iron have found are commonly causes staining of teeth, and that is not good for the patient. That's why they should be taught how to swallow iron syrups without touching teeth to avoid staining of teeth. These are some of the common principles involved in the treatment of a patient with oral iron. The total dose of oral iron must include elemental iron of 200 milligram in 3 divided doses per day. Okay, so for example, let's consider this formulation Fersolate, as I mentioned earlier, which is a 200 milligram tablet. Although it is a 200 milligram tablet, the elemental iron content in that is just 60 milligram. So if you give 3 doses of Fersolate per day, it will sum up to 180 milligram, which is approximately 200 milligram of elemental iron per day. It's important to know that fersolite also has copper sulfate and manganese sulfate in addition to ferrous sulfate. All right, and remember that fersolate is a 200 milligram tablet, but the elemental iron content is just 60 milligrams. The periodic dose for elemental iron is about 3 to 5 milligram per kg of body weight. These are the various adverse effects associated with oral iron therapy. This includes epigastric pain, heartburn, nausea, vomiting, bloating, staining of teeth, which is very common with the syrup formulations, metallic taste. This is even more common, and this is one of the very important reasons for hyperemesis gravidarum, which occurs in pregnancy in the first trimester. That's why iron tablets are usually avoided in the first trimester of pregnancy. A patient who's on oral iron can develop either constipation or diarrhea, but the most common side effect which they develop is constipation. Now let's talk about parenteral iron. Parenteral is any other route rather than oral route, as you all know. And the most commonly preferred routes for iron administration are intramuscular route and intravenous route. The indications of parenteral iron therapy is when oral iron is not tolerated by the patient. For example, if the patient has severe gastritis, if you're going to give that patient oral iron, that's going to worsen the gastritis. And if the patient has malabsorption syndromes where giving oral iron is not going to have any benefit because absorption of iron is not going to take place. If the patient is non-compliant to oral iron, if there is severe deficiency with chronic bleeding, it is important to correct the iron reserves in the body as soon as possible. So that will be beneficial, that will be possible with parenteral iron rather than oral irons, which will take a bit more time than parenteral iron in replenishing the iron stores of the body. If you can treat a patient with erythropoietin, it's better to supplement them with parenteral iron rather than oral iron. And it has been found that when parenteral iron is supplemented with erythropoietin therapy, the replenishment of iron stores in the body was found to be more quicker when erythropoietin is supplemented with parenteral iron rather than oral iron. The various parental formulations of iron available are iron dextran, iron sorbitol citric acid, ferrous sucrose, ferric carboxymaltose. Of these, iron dextran, ferrous sucrose, and ferric carboxymaltose are commonly used, and iron sorbitol citric acid is found to be associated with various adverse effects, so it is not commonly used. The iron requirement for individual patients can be calculated with various formulae, and this is one among those formula, and it's quite simple. You just have to multiply 4.4 with body weight of the patient, and it has to be multiplied with the hemoglobin deficit for that patient, and that will give you a rough value of how much iron is required for treating that patient. Now, iron dextran, it is one of the most commonly used formulations of parenteral iron, and it is a high molecular weight colloidal solution. It contains 50 milligram of elemental iron per ml. All right, and the very important point to remember is that it is the only parenteral preparation that can be injected both intramuscularly as well as intravenously. And anaphylactic reactions which occurs because of the dextran component in the iron dextran formulation is very common, and that's the only thing which bothers us while treating a patient with iron dextran. We should be very cautious about that. We should take precautions, and we should give a test dose initially to make sure that the patient is not allergic to dextran, and then we should cautiously provide iron dextran to the patient. Okay, let's see the dosage of how to provide iron dextran. Okay, so in the intramuscular route, you can give either 2 ml of iron dextran daily or on alternate days, or there is another alternate option in which you give 5 ml of iron dextran on each buttock on the same day. Okay, and this is equally effective than the other dosage which I mentioned, but the problem is that when we are giving such a high dose at the same time, it has been found to cause more local pain compared to giving lesser doses on lesser repeated doses. So it's better to give um 2 ml daily or on alternate days rather than giving higher doses at the same time. And remember that while giving intramuscular route of iron injection, you should remember to use the Z technique, where you stretch the skin in the pattern of Z and you administer iron injection. This is mainly to provide staining of the clots because of the iron formulation, which can come back out of the skin and it can stain the clots, and that will not be good. To prevent that, you must use the Z technique to administer iron formulations intramuscularly. If you want to know how Z technique is being done, you can search in YouTube and you'll find videos on how to do that. Now, intravenous route. So, as I've told you, iron dextran is associated with anaphylactic reaction because of dextran component. And so, to make sure that the patient is not allergic to dextran component, first of all, we should provide a test dose of 0.5 ml of iron dextran. That is given intravenously over 5 to 10 minutes slowly. Okay, and followed by which, if the patient doesn't develop any adverse effects, you can provide 2 ml iron dextran intravenously per day. Or there is one more option where you can provide the total dose at the same time in one sitting. Okay, the total dose is diluted in 500 ml of glucose or saline solution, and it is infused intravenously over 6 to 8 hours. That is another option. And you should make sure that if the patient develops any side effects like giddiness, paresthesias, or tightness of the chest, which can start occurring at any point of time during the infusion, and you should make sure to stop the treatment as soon as the patient develops any such complications. The adverse effects associated with iron dextran are, if injecting the drug intramuscularly, they can develop pain at the injection site. There can be pigmentation of the skin. As I've told you, like iron injections are known to cause pigmentation of the skin, and they can cause sterile abscess. Sterile abscess is the one which means that there is no pathogenic organism present in the abscess. It is just because of a foreign object introduced inside the body. For example, we are introducing iron formulation through the intramuscular route. If it is not getting absorbed properly and if it stays there for some time, it can develop into abscess. But remember that this is just a foreign body reaction and not caused by any pathogenic microorganism. The systemic adverse effects are fever, headache, joint pains, flushing, palpitation, chest pain, dyspnea, lymph node enlargement, and all the non-specific symptoms. Anaphylactic reaction is rare but still you should be very cautious because it is life threatening. It can lead to death also. Now let's talk about ferrous sucrose formulation. Ferrous sucrose formulation is safer than the dextran because it is found to be causing lesser anaphylactic reaction, lesser incidence of lesser anaphylactic reactions compared to the iron dextran formulation. It is given as 100 milligram intravenously for 5 minutes. Now we can see that it is given intravenously only. It should not be given intramuscularly. But you have seen that the previous formulation, iron dextran formulation, is the only drug which can be given, only iron formulation which can be given intramuscularly as well as intravenously. Ferrous sucrose found to be associated with milder side effects than ferrous dextran, iron dextran, and usually test dose is not required, but the British guidelines suggest that you should give test dose for that also to make sure that the patient is not allergic to ferrous sucrose. Now, ferrous sucrose is indicated for anemia in kidney disease patients. For example, if the patient has chronic kidney disease, if you give iron dextran, the patient will not be able to metabolize dextran, and that will be causing so much of adverse effects. But if the patient is a chronic kidney disease patient with anemia, if you're going to treat them with ferrous sucrose, it's not going to cause much of adverse effects in them. So there is recommendation that you can use ferrous sucrose in a patient, in a chronic kidney disease patient with anemia. But it has been found that even in those patients, even while treating with ferrous sucrose, milder adverse effects have been found to occur in those patients, but it is somewhat better than iron dextran in treating chronic kidney disease patients. Now about ferric carboxymaltose. It is actually the structure of that is actually ferric hydroxide core will be present, and the core is of ferric hydroxide, and it is surrounded by carbohydrate shell which stabilizes the structure, and the dose is 100 milligram given IV every day, or it can be given in a total of 1000 milligram is diluted in 100 ml of saline and can be given at the same time. For this drug also, you should remember that intramuscular fluid should not be given, and it has been found to be found to replenish the iron stores very quickly, and they're found to be associated with very mild side effects. Acute iron poisoning is one of the very important adverse effects we should need to consider. It is very common in pediatric patients like infants and children than adults, but it can occur in adults also. It occurs mainly when you're going to treat a patient with higher doses of iron at one point of time. Okay, so if you're going to administer so much of iron without calculating the dose properly, it is it occurs commonly. And remember that it is common in pediatric patients, and the manifestations which are commonly seen are non-specific symptoms like vomiting, abdominal pain, hematemesis, diarrhea, dehydration, acidosis, cyanosis, convulsions, shock, and even death very rarely. And hemorrhage and death is very rare because I meant to say that usually in the initial when the initial symptoms start to manifest, the doctor should be aware that some complication is setting in, and he should stop the therapy, and he should make sure to do something to correct the situation so that the iron poisoning gets corrected and death can be avoided if proper intervention is provided. So, hemorrhage and inflammation in GIT, hepatic necrosis, and brain damage are the pathologies which occur in a patient with acute iron poisoning, and these are responsible for all the manifestations. The treatment of acute iron poisoning involves three main principles. Before knowing the drugs, it is very important to know the three principles involved in the treatment of acute iron poisoning. First of all, you should prevent further absorption of iron from the gut. Okay, like if you have provided so much of oral iron formulation for the patient, and you should and the first step which you should do is to prevent further absorption of iron from the gut. For that, you should give emetics or some other drug to induce vomiting in the patient, so that the remaining iron formulation in the gut gets emptied. And remember that that is one of the very important step. But even more than that is that we should prevent the already absorbed iron from entering the circle. Like the iron which is already absorbed in the circulation has to be removed from the circulation. For that, the drug of choice is desferrioxamine. Remember this drug, this is very important to know. And remember that oral charcoal is not going to be so effective in treating acute iron poisoning. The drug which binds and remove the already absorbed iron is desferrioxamine, and it is the drug of choice. And in addition to that, we need to provide very supportive measures to the patient. This is to this is for the completion sake. You must know the recommended dietary allowance of iron every day, and it varies from various age groups. For example, for adult males, it is zero point 0.5 to 1 milligram per day. Adult females, 1 to 2 milligram per day. For infants, it is 60 microgram per kg per day, and children, it is 25 microgram per kg per day. And for pregnant women, it is 3 to 5 milligram per day. You can see here that the requirements for infants is more than the adults, and for children also it is slightly more than the adults, and in pregnancy the demand increases than a normal adult female, as you can see here. These are some of the common diet sources which are rich in iron. This includes liver, egg yolk, oyster, dry beans, dry fruits, meat, chicken, fish, spinach, banana, apple. The best source of iron is meat. That's because it is rich in heme iron. Okay, so heme iron is the most easily absorbable form of iron. If the patient is a non-vegetarian patient, you must advise them to take lots of heme iron formulations, like they can be advised to take meat and all that, so that that will increase the replenish the iron stores even more easily. So in order to get a brief a much more clear understanding of the um, physiology and all that of the iron absorption and the treatment of the patient with hematinic drugs, it's very important to know the physiology of iron absorption, the mechanism of iron absorption. So I'm going to make a blog in detail explaining the physiology of iron absorption. That's going to be released very soon, so make sure to keep checking my blog. And in my second part video on hematinics, I'll be talking about maturation factors like vitamin B12, folic acid, and erythropoietin. Please make sure to hit the like button and share this video to your friends, and most importantly subscribe to my channel, because we are nearing 3,000 subscribers. And if you like my videos, make sure to support my channel on Patreon. The link is in the description of this video. And thanks for watching, and I'll see you guys in my next video.